And of course, a question you should consider is, do you and your patients really want to know the mosaicism, the presence or absence of mosaicism among your embryos, and if there are any governmental regulations with regards to it? So prior to even speaking with the patients, don't make general assumptions around their knowledge. Don't assume that they automatically want PGT-A. They may simply be looking for information with regards to testing, understanding their options. Some patients may be willing to embrace a child with disabilities rather than have no child at all. And some patients will have to weigh the costs and benefits of the test through their IVF journey, and of course weighing their needs. So it's crucial that there is clear communications between the patient and the clinic and the physician of understanding all there is to know about PGT-A, and of course that the testing is not 100% accurate, and the internet can provide misleading information about the test accuracy and performance and set false expectations. So it's important to have your patients well educated when it comes to PGT. And this is a question that often comes up. Is biopsy risky for the embryo? It's a question that I would love to know your opinion on what do you actually, how do you answer this question? Every biopsy that's done in the States is done on day 5, and embryologists are obviously biopsying away from the inner cell mass. And there is latest evidence that shows that there's no difference in embryo development between those biopsied and those that are not. And lower implantation rates and live birth rates are not seen with biopsied embryos. Does PGT-A affect the number of embryos that you have for transfer number of transferable embryos? Obviously, PGT-A is going to be screening for aneuploidy. So once you identify whether the embryo is normal or abnormal, your prioritization for transfer is going to change, and therefore you're likely not to transfer an abnormal embryo. So it is going to reduce the number of your embryos available for transfer. So having that understanding with the patient is really important. It does reduce the risk of miscarriage and reduce the risk of transferring an embryo that's not going to lead to a viable pregnancy. But obviously you cannot change the number of good embryos. It simply tells you whether they are normal or abnormal or something in between if you're looking for mosaicism. So the important thing here is that the use of PGT-A improves overall IVF outcomes by reducing the problem with maternal age. As women age, they're producing less embryos or less euploid embryos, and therefore doing PGT-A would eliminate this altogether, thus increasing the live birth rates. What if a patient has low ovarian reserve? If a patient is likely to have 2 or 3 embryos, does PGT-A, is it a viable option? Is it the same? Are you weighing these options with the patients? It's basically the same rule applies here, that the chances of success of 1 or multiple embryos is relatively the same. PGT-A testing is offered on per embryo, therefore it's instead of per cycle, so it's scalable and more cost efficient. Those with low ovarian reserves may have a greater benefit because their need to find the euploid as quick as possible, potentially having multiple stimulation cycles and thus receiving multiple embryos that could be tested and thus viable or euploid embryos. What if the patient doesn't have any euploid embryos? What's next? Is this being talked among the patients at all? Is it being discussed that the potential is there for having absolutely no euploid embryo? Are they understanding that this may lead to nothing to transfer? And this also brings up the part about mosaicism, but I'm going to let David Grimes talk more into it or about it later on at 1:40. But it's important for clinics to have a strong policy around transfer of embryos after testing. Just because one cycle is all aneuploid doesn't mean that you stop there. Chances are that there may be some euploid in the next cycle. But each patient needs to understand all of the options when it comes to PGT-A testing. And basically, if all of the repeat cycles result into no euploid embryos, what are the next options? Do they move on to a donor, or are they going to consider adoption, or acceptance of the outcome as is? Is this something that they're willing or okay with? Limitations of PGT-A. So this is something that we try, as a company, we try to make sure that we make everyone aware of limitations of the testing, obviously. It's important to discuss resolution. At Cooper Genomics, we are able to see between 5 to 10 megabytes of resolution. There is an assumption that trifectoderm cells are not representative of the inner cell mass. Again, this plays into the whole mosaicism that if you're taking a biopsy from the trifectoderm, is that a true representation of the inner cell mass, which then develops into the fetus. And of course, there's a lot of work around endometrial receptivity testing and other biological phenomena. How do you discuss limitations? Are you speaking to them about the text platform? Are you talking to them the different options and different methodologies that come with this testing? And do you have a goal for patient and physician? Is this being discussed in conjunction? Are the patients really aware of everything that goes on to PGT-A and its limitations and expectations, basically? So just to kind of end this short presentation is that there's well-published benefits that PGT-A definitely mitigates the effects of maternal age. It does increase implantation rates and reduces spontaneous miscarriages while increasing ongoing pregnancy rates. And of course, it enables efficient, confident single embryo transfer, thus reducing high-risk multiple pregnancies. So thank you so much.